Hi, I'm Marilyn Thorpe. I'm a psychiatrist at University of Victoria. For 22 years, I worked in London, Ontario as an adolescent and young adult psychotherapist. I came here 3.5 years ago. When I got here, two young psychiatrists, Dr. Burrell and Dr. Cheek, were working on putting together a treatment program for people who had difficulties managing their emotions. 2 years ago, we got funding from SSC, the Specialist Service Coalition, and we've worked at putting together an entire treatment program. So what I'm hoping to do today is help you understand how diagnoses are made in psychiatry versus symptoms and severity, help you understand symptoms of emotional dysregulation. I'd like to teach you about the neurodevelopment of symptoms and review some of the treatment options and some suggestions for moving forward. The things I'm going to teach you are typically taught to a patient while they're in a psychotherapy, because I think most patients, it's helpful for them to know and understand this information. In psychiatry, people often want a diagnosis, and in order to bill the Canadian government for seeing a patient, we have to have a diagnosis. There are some problems with diagnosis. In the early 1900s, when people started to produce research, we discovered that in Europe, what they called schizophrenia, we were calling bipolar illness in North America, and vice versa. People tried to come up with a set of diagnostic categories so we would all use the same words for the same illnesses. When I graduated, I had actually memorized the particular diagnostic code at the time, which was called DSM-3. And I thought, there we are, I understand psychiatry. So 25 years later, we've gone from the DSM-3, Diagnostic Statistical Manual, to the 4, to the 4R, and we're now at DSM-5. As I get older, I am much less married to the idea of a diagnosis. I'm much more interested in how a patient feels and what symptoms bother them. The problems with diagnoses is they can change over time from mild to moderate to severe and vice versa. They don't tell us anything about what each patient is suffering. In these emotional dysregulation problems, with treatment, a patient actually evolves away from a diagnosis so they would no longer meet the criteria. There's a lot of stigma and misunderstanding about diagnosis, and I think it's often a matter of semantics. So I am not worried as we introduce this program to you what you think your diagnosis is or what it actually is. I'm much more worried about how you're feeling about yourself and your life. I want to go through a set of symptoms and emotions that people can feel in a cluster together. The first one is there are a set of people who have disturbed interpersonal relationships. I'm not talking about one breakup with one partner. I'm talking about a series of relationships with partners, with friends, with family members, where they're always jumbled up. They start quickly, they end quickly, they're on again, off again, back and forth. Sometimes the person with these symptoms does a come closer, stay away. So it's very ambivalent whether they want the relationship or not. And people with this have a real struggle with I hate you and don't leave me. Very ambivalent about being close. The second thing that people feel is abandonment fears. They're always afraid they're going to get left, someone will stop liking me, if I can't guess what you want me to be and be who you want me to be, that you'll leave me, I'm going to do something to mess this up, everyone always leaves me and all my relationships end up ending anyways. These people describe feeling like they're on an emotional roller coaster. The fancy psychiatric words for that is affective lability. So they feel like 1 minute they're really happy, then suddenly they're fiercely angry, then suddenly they're very sad, and it just seems to go all over all the time. I'm not talking about when someone gets a depression and they feel really badly and withdrawn and nothing budges them for a month or 2 months. I'm talking about this very rapid emotional roller coaster where often people who suffer from it say, I have no idea what triggered this. All of a sudden I was upset. All of a sudden I felt better. And they really do feel like something is almost remotely running their emotions for them. Part of that is a typical kind of anger, which is sudden, it's fierce. This kind of anger is often followed by a profound guilt and a regret for what they've said. They often are accused of overreacting. This is totally out of proportion to what just happened. It is absolutely a raging anger, and they feel like it comes out of nowhere. It feels profoundly justified. Impulsivity. These people get sudden impulses that they want to do something, this is a good idea, and they go with it. One of the things I've learned as I've gotten older is that there are two sets of people. There's a set of people who think too much and try and sort everything out, and there's a set of people who feel the way they feel and they do it. Typically, psychiatrists try and help people who think too much about everything think a little less and trust their feelings. And with the other people, we suggest you slow down your feelings and think about what's going on and why you're feeling how you feel. So these people will impulsively act out on their feelings, and then they find themselves in, how did I get here? For example, suddenly decide that I want to go to UVic and transfer out here, and here you are, and then go, why did I make this decision? Another issue that people in this cluster of symptoms have difficulty with is identity disturbance. They have all their lives felt like, I don't know who I really am. I'm always trying to be who I think you want me to be. They talk about having a false self or putting on different selves for different people. They're not sure what they think and what they really believe because they're so busy adapting to other people and what they imagine they are looking for. This is different than when I'm at work or giving this lecture, I'm behaving in a certain way, and when I get home, I'll kick my shoes off and relax. We all act differently at different times, but who I am and what I believe stays the same no matter where I am. These people don't feel like that. They feel like they're not even sure who they are and what they really want. The S stands for self-harm. And typically self-harm is related to an anger. So that someone gets very angry, feels badly, and then harms themselves. The most classic one is cutting someone's wrists. That is not done as a suicide attempt. People describe several things. They describe being very angry, feeling guilty, feeling numb, and then cutting themselves to either see something to verify that they're still alive, or to stop the inner emotional pain, or to wake them up from a numbness. The recurrent idea of I should be dead, I wish I was dead, maybe I can just be dead. One of my patients described as her default setting, that she was invariably going back to feeling suicidal through her life. The E in the mnemonic stands for emptiness. These people feel a profound inner emptiness. It's pervasive. They especially feel it when they're alone. I'll talk to you a little bit about why I think that is when we talk about the neurophysiology. So they have this empty, alone feeling, and they often avoid being by themselves because it's just too painful. The last symptom that comes in this cluster, and it's not there for everyone, it is dissociative episodes. These take several forms. One is that someone ends up overwhelmed with emotion, sitting, staring off into space, and can't account for the time that they were doing that. There are also two anxiety symptoms that fit into this. One is called derealization, and what that is that someone suddenly feels like the whole world around them isn't real, that they're in a Salvador Dali. The second one is depersonalization, and that's when the person themselves feel like they're not real, but the rest of the world is. These symptoms, the 9 of them, form what we presently call borderline personality disorder. We've had a lot of debate when we've done these lectures live with students at the university about what a lousy name this is. It implies that your personality's messed up or disordered. it's not a good name. And the old word borderline used to be used in a schizophrenic sense, but it's the name we have, and I'll talk to you about what I wish the name was later. So in that diagnostic criteria, there are the 9 symptoms we've talked about. At any point in time, depending on what diagnostic statistical manual we're using, someone needs 5 or 6 of those 9 to qualify for the diagnosis. The other thing about any diagnosis is that it has to interfere with your ability to function within yourself and feel happy within yourself, your ability to function with people in relationships, and interfere with either your ability to work or to attend school, so that the symptoms are so overwhelming you can't function in any of the 3 places. Like all medical illnesses, it could be mild, moderate, and severe. And what we know is that any illness is worse when someone's in a crisis. Someone with diabetes, if they're in a massive emotional or physical crisis, their diabetes gets worse. So when someone's under a profound amount of stress, say exams at university, and they had a borderline personality, their symptoms would flare up. At other times when life's going along, symptoms decrease. This is a picture painted by one of my patients. I love this picture because it shows, she considers it a self-portrait, but it shows how desperately she wants to hang on and how desperately much she loves, but the innate idea that she'll destroy people, that she'll tear them apart and devour them. That huge dilemma these people are in. When she first started therapy, she gave a list, like all my patients do, of what she'd like to see changed. And I have her permission to share it with you. So this is a 16-year-old, and she said she wanted these 8 things out of therapy. I'd like to feel sad without being suicidal. I'd like an occasional day where I didn't wish to end it all. I'd like to think of my life as connected, like a story. She's someone who could give you bits and pieces, but she couldn't figure out how they fit, and nothing made sense in the long trajectory of her life. I'd like to stop thinking about death on a regular basis. Do you see how this death thing comes up over and over? I'd like to not bottle things up. I'd like to feel complete when I'm with other people. I'd like to have my own personality. Now, I knew she had her own personality, but she didn't feel like that. She felt like she was editing for everyone all the time. I'd like to not feel nervous with other people. I'd like to feel like an equal. That shows that always feeling like she has to live up to someone else's standards. A lot of time people argue that this diagnosis is very similar to post-traumatic stress disorder. So let's talk about that for a minute. In post-traumatic stress disorder, there has to have been a trauma. It could have been an acute trauma, or it could be chronic, repeated, multiple traumas. And in order to get a diagnosis of post-traumatic stress disorder, you need some of 3 sets of symptoms. The first are symptoms of increased arousal. So you're watching all the time for trouble, you're startled really easy if there's a noise, and you act and feel all the time agitated as if it's going to recur. So your adrenaline's high, your heart's thumping, you're breathing faster, you may be sweating. They also have intense distress with any kind of cues about the trauma. Their whole body physically reacts as if it's happening. I want to use an example to help you understand. If we talked about a child who was kidnapped by a man in a yellow tie with a white van on their way to school. Anytime they're walking to school, they're watching for a white van. If a car backfires behind them, they will startle. They will feel if the van slows down, like, oh, it's going to start happening again. They'll get sweaty, their heart will race, and they'll have all kinds of physical reactions as they're walking to school. The second set are re-experiencing the trauma. So typically people have recollections of it, or in younger children, they reenact. So over and over again through the day, you go back over the trauma over and over. Very typically after a trauma, someone dreams about it over and over. We know from small children, and even children who can't talk when the trauma happened, that they will replay the trauma. They won't understand what's happened, but they will show us over again in a playroom. Lenore Ter's work on trauma and little children was even able to show that, for example, if we go with the white van and the yellow tie, that child, when they play with their neighbors, is very likely to play a kidnapping game. They'll have their white van, and the play becomes so frantic sometimes that it's infectious, and other kids start to dream about a white van and being kidnapped too. The third part of post-traumatic stress disorder is avoidance. So you avoid the activity. So a child would avoid anywhere where there might be a white van, gradually doesn't want to walk to school, and they often will just sort of withdraw and become more and more isolated as their symptoms are interfering in their real life. If we thought of borderline personality disorder as the response to a chronic trauma, and I'm not saying, and I'll tell you a bit about this in a minute, but I'm not saying anyone intentionally caused a trauma, though sometimes they have. So if it was repeated trauma, and if the trauma was that early relationships really didn't work and were very distressing, and that's the trigger, then when we start talking about a borderline personality as an increased arousal, we would have their fear of abandonment that comes up all the time, their sudden anger when, as we trace it, something's frightened them or hurt them, and the response is to get angry, to protect themselves, and their emotional lability, that emotional roller coaster, would be part of that overdrive of their anxiety and their physical reactions. And it can feel like panic to patients with borderline. The re-experiencing would be then how it somehow, that trauma gets played out in their disturbed relationships. So they're so sure you're going to leave them or not like them anyway, that they act in such a way that you leave them or don't like them anyway, or they leave you first, and then they feel badly. So that could be played out. The avoidance would be the social withdrawal we sometimes see in borderline personality, the dissociation where they just zero out from all the emotion, and that suicidal default setting as a way of escape over and over. There are two problems with seeing borderline personality disorder as a post-traumatic stress disorder in my mind. One, people who've been traumatized, pure and simple, still have a sense of identity. They know very well who they are, what they think, what they believe, what their truth is. The second one is that people who've been traumatized are not likely to be impulsive. They are very likely to think it through, be careful, and want much more control of of the situation than to just go ahead and do something. They often become very frightened of their impulses. So I want to explain to you what goes on as people develop a borderline personality disorder. We know that the lower down you are on the food chain, the more your brain is completely programmed when you are born. So a turtle gets out of his shell and knows enough to run across the sand, get in the water, swim like crazy, and grow up and knows what to eat, and eventually will know, somehow programmed in their brain, to turn around and come back there to lay its eggs, and we keep doing this cycle. They know how to dig up the sand, they know it all. A bird isn't born knowing how to do all of that. It is fed, and its mother teaches it to fly, but then it will go on and know how to build a nest, how to find a mate, a whole bunch of things that it will automatically know. So our brainstem coming off our neck into the base of our brain is quite programmed for all of us. How much more of our brain, the cortex, is programmed depends on how primitive we are. So monkeys, humans, very little of us is already programmed. There are two fundamental programs that you've probably learned about in psychology. The first one is a grasp reflex. So if someone puts their finger in our hand when we're a baby, we will hang on. Everyone thinks that's cute. My baby loves me. Your baby can't let go. Which is why you see kids trying to get rid of a rattle when they're a little older and start to cry. They get frustrated because they can't let go. If someone is in a coma, has a brain injury, and injures themselves to that level of their cord, they again get that symptom. It's one of the ways we can tell where someone's coma is. Another one is a rooting reflex. So when someone rubs a baby's cheek, they will go over to suck. These are very handy bonding things. And we all, as we grow older, our cortex will override those very primitive, pruned responses. And they only come back again if we are in a deeply unconscious state where just our brainstem is working. Now here's where things get interesting. In our bodies, we have a sympathetic system and a parasympathetic. Adrenaline, noradrenaline. Our sympathetic system in our body is what is fight or flight. When the sympathetics turn on, our heart rate speeds up, our breathing speeds up, our pupils constrict, and we're ready to move. When the parasympathetics come on, our body slows down, it heals, and it does a bunch of reparative work. When I was in medical school, I was taught that you could run one or the other, as if it was a switch. So you turn one on, you turn the other. They discovered after I finished medical school that this is not the case at all. In humans, we are not born with that switch set up. So what they showed us at conferences was a set of moms and babies, and they would have a camera on the mom, a camera on the baby. They ran ECGs and they could measure brain activity and where things were firing off. And the way a good enough mom and a baby would interact is like this. The mom approaches the baby and looks at the baby looks at the mom, and they both get excited. So they talk to each other and their adrenaline goes up and they're happy and everything's exciting. And then the baby will start to get too heated and the baby will slowly turn away. Good enough mom pulls away and stays quiet, and the baby now turns off their adrenaline, turns on their parasympathetic, noradrenaline, and everything cools down, as does it for the mom. When the baby's back to neutral, the baby will turn back towards the mom will re-engage, and they both start running adrenaline again. This baby heats up, the baby turns away, the mom waits, and it goes back and forth. So it turns out what's actually happening is people interacting with that baby are teaching that baby to turn on a switch and turn off a switch. Turn on a switch, turn off a switch. If mom is troubled, or it could be anyone, but what they showed us was mothers. So then what happens when she approaches her baby? Okay, so let's imagine that mom is already really afraid of relationships and they never go well for her. She has a baby, she wants to be a good mom, she wants to never do what was done to her as a child, which is a pretty normal human wish. So she approaches her baby. The baby is excited to see her, she's excited to see the baby. Their adrenaline turns on, they interact for a while. Now the baby's getting a little too warm, and so the baby turns to the side to take a break and turn their adrenaline off and their parasympathetics. When the baby looks away, the mom gets worried. What have I done? Are you upset? You don't love me? Now the baby's got their parasympathetics on, and the baby turns back to see what's going on with mom, and their adrenaline turns on. So now they have both. And mom's, what's going on? The baby's not happy, so the baby looks away to see if they can get it turned off. Mom gets more upset, baby's turns back, and what ends up happening for the baby is they have this, I think of it as an emotional storm. There's a literally neurochemical storm that goes on and they can't turn it off. When that person grows up and reenacts relationships with other people, if they've been taught that these kinds of relationships are going to set off this storm, then they're frightened coming in, and the second something goes on, they will start, their storm starts, and with their baby then, the storm storm begins that they then teach their baby. So we're not talking about an inherited problem. We're talking about a learned set of difficulties where someone hasn't learned to turn off and turn on. We know now that as children grow, and the more often you run a particular response in a human brain, the stronger the cord, the stronger the neuron gets to pass that message, so that it becomes like a reflex. In the same way that if you're learning to lift weights, the first time you do it, it's pretty spastic. But after you've done it a while, you have a smooth reaction, and you can do that quite well. Our brain works the same, that the more we run over a certain set of responses, the stronger that set becomes. So when we have a patient later who's been programmed to run this way, what we're going to need to do is try and reprogram the brain. We have a great video from the internet that shows what I'm talking about. As you understand from the video that what we want to do now is try to reprune the brain, to try and run a set of responses through the brain often enough to start to override the previously pruned parts of the brain. We don't know in psychiatry whether we can actually stop the original from being there. We do know people can learn to slow it down enough that they run on a different track. It may always be they're tempted to do the other, but they can shift. So we do this in two major ways. One is that we have discovered that there are a set of cognitive, behavioral, learning things we can teach people, and they can practice over and over, and they can learn to slow things down, to calm themselves, to change their behavior. The second thing we know will help people heal from this is to have what psychiatrists call a corrective emotional experience. Ideally, in the olden days, what happened was you had a long-term relationship with a therapist, and in that relationship you would learn slowly over time that the relationship was safe. You would learn how to have a relationship, how to freak out and still be okay because the therapist stays calm. Gradually, the patient would start to pick new friends, better friends. Gradually, they would start to act differently with other people, and people would either change or dump them, but it would be okay because they were being more true to themselves. Obviously, at a university, we can't do a long-term therapy. And I have an idea it wouldn't even be good to start because there's enough difficulty getting through school and the stresses of school. What we can do is start to help you retrain and reprune your brain. And then when you're at a city where you're going to stay after you're done school and you're ready to start a long-term job, then you would find a therapist and work on the other pieces if there are still pieces you need to understand. So what we've done is design a program at UVic that we're posting on the internet, where you would start with this information session and see if this would apply to you. I don't care what your diagnosis is, we're not worried about that. If you're having trouble emotionally regulating and feeling like you're in control and feeling like you're being your true self, then we think this program will help. After this lecture, we are advising people to see the family doctor and make sure that the family doctor thinks that you're ready to do a group therapy. Then you would get an intake package, you would fill it out, and you would have an intake appointment with the intake person, and they also would make sure that you're group ready. By group ready, we mean that you have enough control of your emotions that you are ready to start thinking about it, ready to slow it down, ready to be in a group learning environment. These sessions are not therapy. They are cognitive learning classroom settings where you're taught skills, you can discuss a bit what works and what doesn't, which helps to hear how other people have coped with that. But we're not doing therapy. We want to get you skills so that you can start pruning your brain. So the first module we have that runs 6 weeks is our foundations module. You learn managing emotion skills. You learn some specific mindfulness skills for people with this kind of difficulty, and you learn some distress tolerance skills. Following that 6 weeks, our idea is that then there were a series of advanced modules. We have already run one on distress tolerance. We have run one on mindfulness and establishing your own identity. We are hoping to finish our Managing Emotions 2 module and hoping to do a module on interpersonal effectiveness. And we would hope that these come out in the spring next year and that we can make the modules available online. In the meantime then, I would suggest that you start to become curious about yourself. Start to watch your reactions, start to question them rather than beat yourself up or flip out at yourself. Start to get curious. What is that? Because when we slow things down with patients to what actually just happened, or who looked at you, or who said what, and what you thought they meant or they did mean, you start to understand that emotional roller coaster. There are triggers, you can figure them out. So start to be curious. I suggest that you stop cutting and hurting yourself and the kinds of self-harm that you engage in, and start writing everything down. When I say that to patients, they never do it the first time. So the next session, I make them walk through the exact events that happened. It's painful. We can always find the trigger. And once they start to see that, they start to stop acting it out and start to try and figure out what happened. The third thing I suggest you do is reality test. We all think we're mind readers. You need to check with the other person. Are you really thinking that? Did you mean that? Is this what you think? So that you start to get an idea what you're assuming that got programmed so young you don't even know about it, and what's really going on. I have several cautions. When I first got to University of Victoria, patients were seeing a different counselor each time they were in distress, a different family doctor, they had different psychiatrists, too many cooks. I suggest you get one therapist, and that's all. So if you're doing managing emotions groups, then that's what you're doing. There's been some ideas, and we've had patients who say, oh, well, I'll go still see my individual therapist. It gets too much going. You're trying to simplify pruning your brain. So don't be putting too much in there. It gets scrambled. The second thing that I would suggest is that when you're in trouble, you avoid acting out. It scares people, it gets people upset, and it doesn't get you what you want. You want to know people care, but this starts to drive people away. I got in trouble for saying it once at a meeting, but I'm going to say it anyway. If you're in trouble and you need to be protected, I suggest you go to the emergency department, and I suggest you tell them, I'm in trouble, I just broke up with my boyfriend, can you please help me stay safe while I get myself pulled back together? I don't think it's smart to walk into the emergency department and say, hi, I have borderline personality disorder and I'm decompensating. Then you're into what the labels are rather than what you're really emotionally needing and wanting. And I suggest that the best you can, you tell people exactly what you need. At this point in the lecture, I usually take questions. We can't do that, and I'm hoping that the people who've shown you this lecture can answer your questions. There are some typical questions that we get asked, which is, could I also have a depression or an anxiety disorder with this? Yes, of course. If you have the chemical problem in your brain, it's just going to make this that much worse. And so we use medications to treat that part, those neurochemicals, so you can start working on this. Sometimes people ask about attention deficit and this disorder. Yes, they could exist together. And growing up in a chaotic environment where people can't help you slow things down, or whether there's things happening all the time, breeds the kind of attention problems that we see in attention deficit. So it's possible it's a genetic attention deficit. It's possible it's a bunch of difficult learned mal strategies. It's possible to have other things with this. It's why I'm saying I'm not so worried what we call it. I'm much more concerned that you find ways to emotionally regulate yourself so that you can have the life you want to have. Thanks very much for listening.